Well, good morning and welcome to the eighth and final installment of the AO Trauma North America Live Pelvic and Acetabular Fracture Management Essentials course. We're glad you could join us, and we think we have a really outstanding presentation today. So on behalf of Mark Riley and Dave Stephen and myself, my fellow co-chairs and director, I would just like to welcome you. We really appreciate the support you've given us over the past 8 weeks, and look forward to this final session. Again, just to remind you, this course was really conceived out of the inability of us to be able to present our normal face-to-face course due to the COVID pandemic. This course is modeled after the success of the course of the osteotomy course, really, and other courses that have been done online. And we decided that instead of drinking out of the fire hose, we'd go for the fountain and try to space this out with shorter sessions, an hour and a half to 2 hours over consecutive Saturdays. But we had hoped to make this a hybrid course where we would have a face-to-face session for the cadaveric dissections and small group discussions. We are working now to try to find a way to make that happen. We had hoped to do that in January, but that may not be possible. And it may be moved back even further, but we're still working on that. To remind you, the lectures for all of the past courses for the past Saturdays, as well as this one, will be recorded, and they will be offered. You can review them on the YouTube channel AO Trauma North America, and CME credit is offered for this course. We really have been blessed and lucky to have an incredibly outstanding faculty. And again, one of the advantages of being online is that we can get the very best people without having to worry about trying to fly them in somewhere. So that has worked out great. The sessions today, these will be your presenters. We'll have David ROTHBERG from Salt Lake City in Utah, University of Utah. We'll have Mike Leslie from Yale University in Connecticut. Hans KREDER from Sunnybrook Hospital in Toronto. Ray Wright from Kentucky. Claude SAGI from Cincinnati. Keith Mayo from Seattle and Tacoma, and Eric Johnson from Los Angeles. So we'll have a very full session today. The way the session will work today is we'll have 3 presenters that will give us some didactic speaking. It'll be David ROTHBERG on the pelvic and pelvic ring injuries in children, pediatric pelvic ring and acetabular fractures. Mike Leslie will talk to us on insufficiency fractures in the pelvic ring as we wrap this up with our special problems. And then Hans KREDER will talk about total hip replacement and its role in treatment of acetabular fractures. And then partly for entertainment and partly so we can learn from others' errors and mistakes and bad outcomes, we'll hear from Ray Wright and Claude SAGI. Will present cases when things don't go as they designed them to go, and what lessons we can learn from cases they had that didn't go ideally. And then I would really encourage you to stay to the very end, because we probably will be pushing the limits of our time a little bit, but we're going to have a very special closing, which will be done by 2 of our very experienced people, Eric Johnson and Keith Mayo, which I think will be a very special time, and I really would encourage you to try to stay on board for that. These are the disclosures of our speakers today. A link for this recording will be sent to you 24 hours at the conclusion of it for all those who registered. And after you fill out your evaluation, you can then go to the YouTube channel to view these and be entertained by them, hopefully. Remind you that your microphones have been muted and your videos are turned off. Please, when we encourage you to ask questions, but please use the Q&A tab, not the chat tab. So please use the Q&A tab to ask your questions, and it will be an answer returned. And the moderators will view them. Some of these will be presented by the faculty as well. So with that, I will stop sharing my screen. And I will get David ROTHBERG from University of Utah to share his screen, and we will open the session with a talk on pediatric pelvic and acetabular fractures. So David, I'll turn it over to you.
Good morning. Thank you, Steve. So we are going to talk about pediatric pelvis and acetabulum fractures, and a lot of this has been borne out in my experience living in Utah, where everyone has 5 kids and 2 trampolines. So we tend to see a lot of pediatric injuries despite being a relatively small state. So at the end of this talk, you're going to be able to answer a couple questions. One, what are the operative indications in pediatric pelvis fractures? What are the acetabular fracture patterns, and when and how do I respect the growth plate? So let's start with some of the fundamental differences between kids and adults in regards to their pelvis. Number one is that particularly in the younger kids, their bones, joints, and symphyseal cartilage are considerably more malleable and elastic. Their periosteum is much thicker, so they can absorb a lot of injury, a lot of force before you're going to see anything akin to adult-style patterns. The other major difference is that they have growth plates and apophysis. The one most concerning to us is the tri-radiate at the acetabulum, and injury to that can lead to deformity, which we'll cover. And the other component of this is the physiologic response. So in kids that do have high energy trauma to the pelvis, which at least here is generally kids unfortunately getting run over in their driveway by a car or trailer. What happens with kids is that physiologically, when we're managing the high energy pelvic disruption, they are not going to show the same signs of shock as an adult will until they're really far along and ready to collapse. And so we have to remember that physiologic support of these kids looks a little different, and we have to be wary of when they're going to drop off the cliff. The last part, and a kind of a theme to this talk, will be that utilizing some of the things that you have learned in the adult components of this course are still exceedingly important in the kids. Our tendency is to think that because they're kids, they'll remodel and they'll be fine. But the reality is that many of the injuries that they have are through articulations, and articulations do not remodel. And so this is an example of a kid who had a injury to the pelvis, and you can see the displacement of the right sacroiliac joint. And it was left alone with the assumption that this would remodel, and that what they were seeing on this repeat CT scan at 7 weeks was remodeling. And while you can see the periosteal tube thickening anterior on the ilium, this is not articular cartilage. And I think at best, if in a patient like this, what you're going to see is a fusion of the joint in a deformed position. And so the remodeling in the pelvis is not as significant as it is in the diaphysis of long bones. And I would implore you to remember that. And we'll go over that in greater detail as we move through the talk. So in regards to development in the pelvis, what do you really care about? Number one is identifying injuries. So the pubic symphysis width, what is it at age X? What is the SI joint width at age X? And what size are my fixation core? Or should I have an unstable and displaced pelvis that needs to be fixed? So through CT study, the pubic symphysis width has shown to not differ a significant amount over time. And so the really young kids will have a 5 millimeter width to their symphysis up until about age 12 to 15, when we're having a more adult size pelvis. And you see that really that width stays relatively similar at about 4 to 5 millimeters. The SI joint, or sorry, what you're seeing here basically is a 3-year-old female that had an open book pelvis fracture with significant symphyseal widening and where it should be once it's closed. So you're just seeing an example of what the width of the symphysis should be at that age. What about the SI joint? It differs a little bit more over time, but still it's not significant. In the really young kids, similar to the symphysis, you'll see about a 5 millimeter width of where the cartilage is, decreasing to about 3 millimeters at the age of 16. In reality, in the SI joint, because most injuries are unilateral, not all, but most, you have a template to look. And so you look for side-to-side symmetry, but here's some numbers in case you don't have that. Now, if you have a pelvis that needs to be fixed, and we're thinking about fixing them in the way that we might fix an adult, we then ask the question, is that safe? And do we have the corridors? And so in the sacrum, generally speaking, in most kids, we have very safe corridors with greater than 7 millimeters of pathway at S1 and S2 in a vast majority of patients. So we're starting to see that the symphysis, the SI joint, are not that much wider than in adults. So that makes it easier for us to evaluate instability. And that if we need to fix them, it's actually quite safe to do so utilizing the same techniques as we do in adults. The classification system that you'll see for both pelvis and acetabular fractures are not very good. And so the Tarot and Zieg talks about avulsion, iliac wing, anterior ring, straddler combined, but it doesn't really give us much of an anatomic consideration, and it certainly doesn't help us with stability. So for me, I like to think about these in the same way that I think about adult fractures, both mechanistically with a Young and Burgess, and anatomically in the Letournel type descriptions, as well as stability in the AO or tile classifications. And I think that for the most part, that kind of holds true in kids, that you can utilize those. So for kids that are above 12 to 14 that have a tri-radiate that's closed, I just treat them like adults. And on those that are younger, I'm going to base my decisions on what to do with a pediatric pelvic fracture based on instability, displacement, and remodeling potential, knowing that in general, greater than 1 centimeter of asymmetry in a pediatric pelvis is not going to remodel. And so if you've got a hemipelvis in which you don't have the same hip heights, or if you've got one where you have a significant internal or external rotation to one half or both halves of the pelvis, you can't expect that to remodel, and they need to be fixed. In regards to instability, I think this comes in on the kids that have lateral compression type fractures, and much in the same way that we figure out whether somebody is stable or unstable in an adult, we do the same thing in a kid. I think there's some hesitation to stress a child's pelvis, but the reality is you would not hesitate to give a child propofol to reduce their both bone forearm fracture. And if your hospital's anything like mine, you do that 10 times a day. So why not do the same thing with a child's pelvis fracture that has both anterior and posterior fractures, pelvic ring fractures, that you're not sure whether they are stable. And so that's what we do in our hospital to determine stability, is we use a stress examination. And the reason that I think that that's valid in a kid is because if they stress to a position that is more than 1 centimeter or more displacement, that's where they're going to end up. And we know that doesn't remodel. So what are the non-operative fractures? Basically, almost all the avulsion fractures, anything isolated into the anterior ring, an iliac wing that's not significantly displaced and not into the joint, anything isolated, non-displaced sacrum or SI joint injury without instability that I've tested, and stable combined injuries with less than 1 centimeter of pelvic asymmetry. And I think if you're discerning, you're going to realize that what I just described is basically the same indications for an adult. So how do you do it? This is a 12-year-old female who was ejected, and then unfortunately the car rolled over her. So it took a fairly significant trauma to fracture her pelvis, but she had a significantly displaced fracture. You can see in these imaging that she has a binder on right now for hemodynamic instability. You can see the displacement of the symphysis, the tri-radiate on the left. Here is a CT scan with representative cuts. She's got a left sacroiliac joint fracture dislocation, right sacral fracture, a symphyseal injury where the symphysis is not quite matching up in the middle, but has been reduced by her pelvic binder. She's got an anterior column tri-radiate based acetabular fracture on the left and inferior pubic rami bilaterally. So this young lady was hemodynamically unstable and had a belly injury. So the same as we would do with an adult, we took her to the operating room that night in conjunction with general surgery. We evaluated for perineal open wounds. We washed out what we needed to, and we closed down her pelvic volume, much in the same way that we do with an adult. And you can see the S1 which we said was safe in most kids, S1 iliosacral screw on the left, and a fairly good reduction in the front. She stabilizes, and we measure that just in the same way we do with adults, where we're checking on blood pressure, hematocrit, lactate, looking for resuscitation parameters, and then take her to the operating room for fixation of what was a displaced left acetabular fracture, and fix the front to help us with gaining an anatomic reduction of the acetabulum. So this, you can see this is a kid who's older than 12. We said the tri-radiate closes at 12, and despite the fact that she fractured through the tri-radiate, we know there's not significant growth left, and we cross the tri-radiate with a recon plate. And this is her 1 year post-operative. We elected not to take out the hardware because she is nearing skeletal maturity. Now, this is that same 3-year-old before. Again, this is another kid who's run over in the driveway, and has an open vaginal laceration with bleeding per the vagina, and an open book pelvic fracture. And just like an adult, we're going to examine the genitourinary system. We go to the OR with OBGYN. We open her up through a fan and steel. But this time, with the size of the patient, and knowing that because she has a significant amount of growth left, and that we have an apophysis on either side of the symphysis, we choose to get her reduced and actually suture fix the symphysis. Now, that's not strong enough over time, really, to be by itself. And so she gets an anterior-based X-fix, but the suture fixation allows us to have washed out the open pelvic fracture, get a good reduction on the symphysis. And here she is at 6 months with some residual deformity that is less than 1 centimeter, and we would expect to remodel. So we've been talking a little bit about the tri-radiate cartilage. So talk about what happens when it's injured. And it seems that for the most part, this actually happens significantly more in pelvic fractures than it does in acetabular fractures, despite the fact that acetabular fractures are going to fracture through the tri-radiate. The reason for that being that older kids are the ones that are getting acetabular fractures by and large. And so you're not seeing a lot of deformity from growth arrest in the tri-radiate, versus pelvic fractures that can happen at younger ages or seem to mechanistically. And so you may get fracture akin to a pubic root fracture that goes through the tri-radiate. So I'm just showing a picture here of a 1-year-old, and you can see a significantly large tri-radiate versus the image of the older child with the arrow showing you where the tri-radiate is. And it's a fairly T-shaped cartilage pattern along the quadrilateral plate, extending out to the rims both anteriorly and posteriorly. So the significance of an arrest is that if it happens at a young enough age, what you see is somewhat akin to DDH or developmental dysplasia, but it's a little different, because in developmental dysplasia, you see an anteverted femur under coverage of the lateral and anterior component of the acetabulum. After a pelvic fracture, a tri-radiate injury, what you see is teardrop thickening, some lateralization and cranialization of the head. And it depends a little bit on where the tri-radiate was damaged, whether primary, anterior, or posterior. But this is a kid who wasn't really caught over time, and now has lateralization and uncovering of the head because of a tri-radiate cartilage. And this is a patient that I took care of this year, who was treated at an outside hospital, had a very reasonable reduction of the pelvic ring and appropriate treatment at 6 years old. And the outside surgeon noticed that the right tri-radiate started closing down from this pubic root fracture. This was a non-articular fracture, but did involve the anterior column component of the tri-radiate. You see a bar forming here at 9 months. And starting to see the head lateralize. So there's more uncovering here of the head. And so just like any other physeal bar in a young child, we're going to resect that. And so that's a picture of what we did. This was through the middle window. And you can see down here where the bar now is gone. This is an intraoperative photo showing you through the middle window. We've got vessels here. This is healthy cartilage. This is the area here where we resected the bar. And she's only 6 months out now. So we'll, if you come back next year, I'll show you where she's at. So taking you from that, we'll move on to acetabular fractures. These are pretty rare under 10 years of age. We don't tend to see the mechanism causing acetabular fractures at that age. We do tend to see pelvic fractures, but not acetabular fractures. We said that the tri-radiate closes somewhere between 12 and 14, depending on sex and physiology. And so this is a pretty small window of kids that are going to have an acetabular fracture that is different than the adult. So this is an 11-year-old male with a posterior wall fracture dislocation versus a 13-year-old male with a posterior column-based fracture here through the tri-radiate. And we'll go through in a little more detail this in a second. The original classification for these is the Watts classification. I do not find this helpful whatsoever. What we have learned about the Letournel classification is that it helps us to define which components of the bone are fractured and how we can approach it. This Watts classification doesn't do that. So for me, I don't really put a lot of stock in it, but instead start to lump pediatric acetabular fractures in 3 groups: elementary wall patterns, fractures with tri-radiate involvement, and those with adult patterns. And so once their tri-radiate is closed, we're not really talking about a pediatric fracture anymore. They tend to just be adult acetabular fractures. And so kids will get posterior walls, elementary anterior walls as well. And then the fractures that they have through the tri-radiate are either going to be anterior, posterior, or both based fractures through the tri-radiate, meaning either low anterior column, low posterior column, or T-shaped fractures. And I'll show you some examples of that. This is an elementary wall in an 11-year-old who was playing football and was landed on his back with a flex knee trapped under him, and he had a dislocation. When you look at pediatric posterior walls, it's very difficult to identify the wall. It's a very small piece of bone up here. Still, some of the rim is cartilaginous at 11. And so hanging your head on any kind of size measurement on X-ray or CT is very difficult. So the same question comes up that you would ask in an adult is the hip stable? And so again, I would implore you to utilize the stress exam like you've learned in adults in kids, because that's what's important. So this kid got a reduction, and you can see that the head is still lateralized. Now in an adult, we would just assume that we probably have some bone in there and put them in traction. In a kid, I want to show you what can happen and tell you why I think when you see this, or really any posterior wall fracture dislocation, this kid deserves an MRI. The reason for the MRI is you see a lot more of that cartilaginous rim structure that you don't see in an adult. And so what happened to this kid, and that I've seen a few times now, is that upon the reduction, the fracture included part of the labrum, and when we pulled the head back in, we actually delaminated the cartilage with the labrum, and that is what's holding the head out lateral. And so what you're looking at here is a coronal image showing the delaminated cartilage and the posterior superior aspect of the hip versus the axial on the left that shows you where the posterior wall fracture is. And so this is a kid that then needs to go to surgery. And we chose to do a Gibson approach with a surgical dislocation. They're 11 years old. You can do a trochosteotomy 9 or older pretty safely without damaging the greater trochanter apophysis. And then we fixed the posterior wall with suture anchors because of the size of it, bringing the labrum back more of a labral repair for stability. And at 18 months, there's no AVN, and healed well and is stable and back to getting ready for his next injury playing football. Now, the tri-radiate involvement fracture, as I said, come in anterior and posterior or T-shaped flavors based on the shape of the tri-radiate cartilage. And so this is a 14-year-old male that we follow the iliopectineal and ilioischial lines, and we see disruption of the ilioischial line. Therefore, we are dealing with a posterior column tri-radiate based fracture versus the 11-year-old male, where you can see that they have the anterior based fracture as well, both coming through tri-radiate here. Here's the CT scan of those. On the posterior based fracture, you can see the displacement through the tri-radiate here that comes down through the acetabular roof. On the 11-year-old, the anterior fracture. So now we've determined, based on Letournel's classification, where this fracture is using our radiographic lines, and it's all starting to come full circle, and now we can choose an approach. So for that the posterior based fracture, they got a Coker-Langenbach approach, much as we would do in an adult. We had a posterior column plate, much like we do in an adult. The one thing that's a little different is that you can see I used a 4-5 cannulated screw as my lag screw. These fractures rotate in the same way that a posterior column would in an adult, but just rather than through the ischiopubic segment, it tends to rotate through the tri-radiate fracture, heading in a caudal to cranial direction. And so the position of the lag screw based on the tri-radiate is a more vertical position. And so when I'm doing, when I've got this fracture reduced, I use a cannulated screw because the trajectory of the lag screw comes from outside of the wound of the Coker-Langenbach. And so that's why I use that. Now in the anterior based fracture, it's going to be an anterior column plate, just like we would in other anterior column fractures. And this is him at 6 months. The question then becomes, what happens in the younger kids where the tri-radiate cartilage is still open? And so we said it closes at 12 to 14. The reality for most kids is that past the age of 10 or so, there's not a lot of remodeling or a lot of growth still going on in the acetabulum. And so that's in general, my cutoff is about 10 years of age, pending what they seem like physiologically compared to their parents or older siblings. But this is a kid who you look at their pelvis and it's small, it's still immature with an anterior based fracture. And so in order to respect the tri-radiate cartilage and not cross it with a plate, we are buttressing cranially and caudally to the fracture line and then using a K-wire across the tri-radiate to stabilize. And that K-wire is coming out this cranially through our lateral window, allowing it to be pulled in the office at 6 weeks. And you can see the reduction of the anterior column here. And so that's my strategy for respecting the tri-radiate, and those under 10 is buttressing on either side of the tri-radiate and utilizing smooth K-wires across the tri-radiate that can be removed. Now, not always do you guess right, and this is what I just think it's an interesting x-ray. This is a kid who got an anterior column-based tri-radiate fixed, was lost to follow-up and did not have plate removal. You can see where the tri-radiate grew and sheared the fractures. So the growth plate was still growing, and as my senior partner would say, behold the power of the human growth plate. So in summary, operative indications in pediatric pelvic fractures are still based on displacement and stability, just like they are in adults, knowing that a kid is not going to remodel greater than 1 centimeter of displacement very effectively. Their acetabular fracture patterns are still going to follow a Letournel style pattern, but be based through the tri-radiate. They will still dictate our approach. And that respecting the tri-radiate growth plate is important based on age, with a generalization of 10 years of age based on projected growth and closure. But there is a little bit of art to this based on, you can have 12-year-old boys that are 5 feet tall and dad's 6'4", and that happens on occasion. And even though that kid is 12, I would still likely respect the tri-radiate because of how much growth is going on. So there's a little bit of art to that. But the major summary here is I still think about these very much like we do adult fractures, and would ask you to use much of the same indications that you would in adults. Thank you.
Great, Dave. Thank you very much. It's a great talk. Well, while Mike Leslie is bringing up his screen to share, let me just ask you one question. So there's obviously a very wide variation in sizes in these kids. So how do you decide on the size of the implants you're using, or do you basically use the exact same things you're using in adults? So
I have never had a whole lot more than go down to a 6.5 cannulated screw for posterior pelvic ring. 3.5 recon plates for the most part are very reasonable until the very small kids, in which I'll use 2.7 recon plates. But for the most part, there's not a huge difference. I still use the same large X-Fix that I use in adults. The corridors tend to be still fairly sizable. And when you take a lateral sacral image of a kid, it shows you the tunnels so much, like neural tunnels, so much better than an adult. It tends to be easier, I think, to stay safe.
Great. Thank you very much, David. That was really interesting. You've got a very big experience with kids, not more than I think the rest of the world does probably. But so our next speaker, we're kind of turn it to the other end of the spectrum, and Dr. Michael Leslie from Yale in Connecticut will talk to us on the fragility fractures around the pelvis and the specifics of their treatment. Now, Mike, I'll turn it over to you.
Great. Thank you very much, Steve. So yes, we're going to flip to the other side of the spectrum here and talk about insufficiency fractures of the pelvis. So really, what are we talking about here? So for the most part, we're talking about senile osteoporotic pelvic ring injuries, which all of us see every day and certainly make up a very significant part of what we're seeing in our offices non-operatively. But we really want to ask the questions about the particular stability and how do we get these patients mobilized. But when we think about insufficiency fractures, we also want to think about the other types of osteoporotic insufficiency fractures, so drug-induced or metabolic in particular. In my practice, this oftentimes includes patients who are on anti-seizure medications who really have very poor bone quality, patients who've been on narcotics for an extended period of time, and then the more traditional metabolic problems that we think about, patients who've been on prednisone for many years or other types of anti-rheumatologic medications. Really, there can be a tremendous population of insufficiency fractures that we think about. We also want to think about pathologic fractures. So with the increasing success of cancer treatments, certainly we're seeing more and more metastatic disease and pathologic fractures. In addition, post-treatment injuries, so patients who have had irradiation of their pelvis for gynecologic cancers can certainly have insufficiency fractures. We want to think about the vitamin D depleted patients, the long-term immobilized patients. So both of these groups of patients can certainly suffer fractures for different reasons. But in the end, we're not really sure why we're even here, because all of these patients are theoretically, traditionally too old for surgery. They can't tolerate surgery, or their bone is simply too brittle to deal with, or maybe we think the deformity just simply won't be that bad. And in many cases, maybe that's the case, but we really want to think about these injuries, much like Dave was saying a few minutes ago, thinking about the pediatric injuries as very much adult type injuries because of the lack of remodeling. On the opposite side of the spectrum, we want to think about these patients really need to be able to mobilize. And we may accept some amount of deformity, but let's really get into that a little bit. So some of the non-osteoporotic concerns, certainly the medical comorbidities that these patients have, the primarily low energy of these fractures, or the high energy trauma comorbidities. We really need to be able to separate those patients out when we think about the elderly patient and whether these are truly osteoporotic fragility fractures or if they are more high energy injuries. We also want to think about prior joint replacements. That's a little bit outside of the scope of this particular talk, but certainly with more and more joint replacement being done, this is going to be more and more of a factor for us in the future. So some of the, in particular, issues in the elderly that we need to think of are metabolic abnormalities that cause both surgical risk and bone healing risk. So anticoagulation, that's probably the most significant thing that we see as far as something we need to deal with. Fractures in the setting of long-term bisphosphonate use certainly has effect on all the bones. It's not just this fracture of the femur that we oftentimes think of. Vitamin D deficiency, hypogonadism, malnutrition, all of these things are very common in older patients. Pelvic fragility fractures in general, we really want to think about ways that we can overcome poor bone purchase by our implants and immediate weight bearing that we require in the elderly. And I like to really think about that as a requirement in the elderly, not something that we can really limit people even for a limited period of time. So we're going to go through a lot of patients. So the first one will be a 69-year-old female who had a ground level fall while dizzy. And this is the fracture that she suffered. So here we see fracture of the superior ramus, that's segmental in nature, and then a completely displaced fracture of the inferior ramus. So she's 69 years old. This was a ground level fall, certainly something that we would think about as osteoporotic fragility type. But we do get a CAT scan and we note that she's got a complete sacral fracture here out in zone 1 of the ala. So for this particular patient, we want maybe non-operative care might be the best thing for her. So we want to think about the tenets of that, and I think we're used to doing this. So the goal is early weight bearing, and in order to do this, patients need some amount of bony stability, either inherently or surgically. That requires DVT prophylaxis and central spirometry, really just good nursing care to get these patients mobilized. There are two parts here that run over some of the high energy injuries. So we think about post-mobilization films. I can't say that post-mobilization films have ever really made any difference for me as far as treating these patients. Maybe once or twice we see some difference, but I really have a hard time seeing any big difference in these patients, likely because they're not mobilizing all that much in the very beginning. And the utility of exam under anesthesia, I think that there's more utility to this than we even think, because it might enable us to identify some fracture components that might help make the decision on whether or not these patients undergo surgery. So when we go back to this patient that we were talking about a few minutes ago, she was completely unable to mobilize on hospital day 3, completely unable to get past the side of the bed. So the decision was made to start with percutaneous stabilization of the posterior pelvic ring and get some compression across those fracture components of the complete sacral fracture. Once that was done, we really want to think about the rest of that ring being stable. So what was done was a stress radiography. And here we see, just with simple internal rotation moments on the left hemipelvis, we see very significant displacement of that superior ramus and overriding of the inferior. So a decision was made at this point to, instead of do a large surgery and really work on an anatomic reduction of that segmental superior ramus, to utilize anteriorly based distraction external fixation to allow this patient to mobilize. And she was allowed to be weight bearing as tolerated on post-op day 1. She slowly mobilized, went to rehab, but then a few months later, she was doing just fine. Of note, with supraacetabular external fixation, we want to think about some of the things that are important there. Think about using the largest pin caliber, and using those pins, hydroxyapatite coated pins might be considered if we need longer term fixation. And then thinking about how you place any anterior clamps, either in the mid portion or on the pins. We want to keep them as far away from the patient's thighs as we can and away from their abdomen so that they can mobilize to the chair easy enough. This patient was fine at 4 months, a little bit of internal rotation and flexion, but overall had a much easier course, we hope, than otherwise. A patient 2 here, this is an 86-year-old female who fell outside a bakery on Christmas Eve. This patient has a very significant injury with shortening of her hemipelvis and a very comminuted fracture of the posterior aspect of her ilium leading into her sacroiliac joint. If we're looking at this fracture in a 20-year-old, we would automatically assume that this patient would be surgical. So we really want to think about that. But in the end, who really needs surgery, and can we classify this? And we have a little bit of guidance from 2013 where this comprehensive classification of fragility fractures came out. And this is a very helpful paper that's worth taking a look at. What it talked about a little bit was the fact that the Young and Burgess mechanistic classification, that's Howe classification, are not as useful for the low energy fragility fractures and more useful for the high energy fragility fractures. And that's really due to the fact that the very strong sacroiliac, sacrotuberous, and sacrospinal ligaments are actually stronger than the bone in the osteoporotic fracture patient. And due to the low energy nature, it's really the bone failure that's happening. Bones can only move within the confines of these constraints if it's a low energy fracture. So it really applies in very different ways than the high energy fractures. So the classification that was brought about was this FFP 1 through 4, broken down into a number of different fracture patterns. And I won't get into too much detail here, but essentially the FFP 1s show fractures of the anterior ring. The FFP 2s show fractures that involve the posterior ring. And the FFP 1s can typically be treated non-operatively. The 2s typically treated with percutaneous fixation if the patient cannot mobilize. And then we think about the FFP3s, A, Bs, and Cs, more complex, complete injuries of the posterior pelvis. And these are ones that we would think about open reduction terminal fixation. And then the FFP4s are more consistent with very significant injuries of the pelvis that oftentimes involve the spine. So we have a little bit of guidance here. And we go back to our patient. So we see this 86-year-old female who fell outside this bakery, and she has this very complex fracture. It's an FFP 3A if we go by this classification. So we would want to consider open reduction internal fixation. However, this particular patient decided for non-operative management. She really didn't want to have surgery around the holidays. So she decided on this. We had an understanding that she would have an internal rotation deformity with flexion of her hemipelvis, but she was able to weight bear and mobilize. This particular patient, this treatment was right for her, and she did return to independence with a small heel lift. So really this can be done for patients. So who really benefits or needs surgery? So those who can't mobilize due to pain associated with instability, those with complete anterior and posterior fractures, particularly those crescent type injuries, although they're usually much more complicated than crescent type injuries, those who have neurologic considerations or injuries, and those who have deformity. Now, or we might consider deformity as a problem. But deformity is not always an indication for surgery as long as we understand what the expectation of deformity is. So here's just a different patient. This is an 82-year-old male who was hit by a city bus. This was actually a pretty high energy injury. Although we wanted to consider him an osteoporotic, he was really reacting as a young trauma patient. So he was treated down a regular trauma pathway with pelvic sheeting and went on to a more standard fixation construct and went on back to independence. Sometimes we don't consider the patients in the correct categories, however. This was a 75-year-old male who fell off a step stool while changing a light bulb in his home in another country. Unfortunately, he was unable to evacuate for 57 days back to the United States, and he was left in this position. He was considered an osteoporotic fracture patient, and in this country that he was in, the consultant chose non-operative care for this particular patient. Unfortunately, he came back to the US in no pain. However, his limb was externally rotated, shortened such to the point that he couldn't even get his foot on the ground. So now this 75-year-old is faced with a much more significant problem because he's so short, so rotated, that now he needs an osteotomy of his sacrum, winds up getting an osteotomy of his sacrum with reduction of his anterior ring. Certainly not perfect. However, it did put his foot back on the ground and allowed him to mobilize and return to independence. However, a much more significant surgery than he would have had if he had originally been able to be treated. Patient 6, on the other hand, is an 81-year-old female who fell from standing position while being struck by a passing car, really glanced by a passing car. And when she described the story, it did not seem like a very significant injury pattern, but we see this very significant displacement of the hemipelvis. She did have other injuries that went along with her being on anticoagulation. However, she was a very mobile, very independent person. So we really wanted to consider her severe osteoporosis and her medical comorbidities as she recovered from her trauma comorbidities. We did consider minimizing her risk, minimizing the risk of bone purchase and minimizing the risk of her being able to mobilize. And eventually she went on to very rigid fixation of the posterior ring with multiple points of fixation, really appreciating all the bone we had to utilize there, and then anterior external fixation to really back up our posterior ring fixation. Now, sometimes that's just not enough and we need to actually support our screws a little bit. So here we do know the concept of sacroplasty or augmentation of fixation. There are some papers written about by both the biomechanics and also the clinical series that are in the literature. And this is the problem that we're talking about. So sometimes we utilize intramedullary screw fixation in order to achieve percutaneous stabilization of complex pelvic ring injuries, but sometimes these screws will back out. Sometimes these screws just don't have any purchase. The potential solution is to utilize fenestrated screws or to utilize cement that is injected through the end of cannulated screws to achieve fixation about the screw. We do see that this is being utilized in proximal femur fractures with certain devices quite successfully. So maybe this is a little bit of an answer for the pelvic ring too. So in the 11 clinical series that were reviewed in this particular paper, there were no major complications. There was minor cement extravasation in both anterior to the sacrum and into the SI joint, but neither of which needed intervention. We do know that in the literature, there's clearly some biomechanical stiffness advantage. Potentially, it would prevent the screws from migrating out before healing. And we do know that sacroplasty alone does improve patient pain in isolated use in spine considerations. So maybe this is an answer. Maybe this would help us a little bit. The last patient we'll talk about here is a little bit of a bonus and something for the future to think about. So this is the unidentified insufficiency fractures. This was a very low energy motor vehicle collision in a parking lot, 68-year-old female. She really had a negative CAT scan on her initial evaluation. We're looking here specifically at her right posterior ring. We see significant osteoporosis, but we don't see any fractures. However, 6 months later, we do see a fracture that is complete through her sacrum. We also see very significant fracture of her low left-sided pubic body that was not present on her original evaluation. So this patient suffered for about 6 months before she got a repeat CT scan, and she was referred. And these are the things we need to think about. And sometimes even the non-displaced fractures have a very difficult time healing. So how can we identify those and help things? Well, we look at vitamin D levels, ionized calcium levels, TSH levels. We might consider teriparatide or surgery. Early evaluation and repeat imaging when patients remain symptomatic without a known fracture is actually pretty important. So we want to pay attention to these patients when they complain of pain. The last thing here is just the use of teriparatide in osteoporotic fracture patients. It does get some favorable use in some centers. Review overall really highlighted its limited use. We can consider it in patients with fractures that we would not otherwise expect to heal due to medical comorbidities and their fracture patterns, but it is very expensive. There's limited data, and it's mostly focused on decreased time to healing and not avoidance of non-union. So it's a little bit difficult to indicate teriparatide use, and there are a lot of black box problems with utilization of this. Some of our last considerations here, post-radiation fractures. Unfortunately, 11.5% of all gynecologic cancer patients treated with radiation suffer pelvic ring injuries within 6 months of treatment. They tend to be very stable injuries, but the pain can be significant. We might want to think about ways to stabilize these to allow their pain to be less. We want to consider all these metabolic issues like we talked about on the last patient there, but also smoking cessation, alcohol abuse, weight-bearing exercise, what are they doing? And we want to consider bisphosphonate use after their fracture healing. In summary, if a patient's unable to mobilize, we want to consider surgical treatment, even if it's a relatively stable fracture, because sometimes the compression may help these patients mobilize. For less stable fractures, it becomes a little bit more obvious, and we can do surgical stabilization, but we want to really consider the bone quality, utilize sacral and column screws with possible cement augmentation, and then the anterior ring is oftentimes very successfully treated with supraacetabular external fixation. Ideally, we want to mobilize these elderly patients, activity is tolerated, make them weight-bearing is tolerated immediately, and hopefully we can get these patients on to successful outcomes without too much concern. Thank you very much.
Great, thank you, Mike. That's a great talk, and an ever-growing problem. Are you guys seeing more and more of these patients, or is it as we had predicted with the baby boomers aging out, or and how often would you say you're operating on a patient that shows up with a fragility fracture at your hospital? Is it once a month, once a week, once a year?
I would say it's reaching once a week at this point. We try to separate out all of our fragility hip fractures, so they're completely done in another center. So really, we're left with the osteoporotic pelvic ring, and we're seeing at least 10 to 15 a week, and then I would say 1 or so a week is actually undergoing surgery. So
that's a lot. Great. Well, thank you very much, Mike. So our next speaker, we'll let him bring his screen up, is Dr. Hans KREDER from Sunnybrook Hospital in Toronto, one of the original seats of pelvic and acetabular fracture surgery in North America. We're pleased to have him back again. We've worked him quite hard during this course, and he's going to talk to us on the option of arthroplasty and how it integrates with treatment following pelvic and acetabular fractures, or acetabular fractures.
Yeah, so this is really the same sort of concept of fragility fractures of the acetabulum. You've just heard a good talk on the fragility fractures of the pelvis. So we'll try and go through that. So I'll do this with a few cases. And this first case is a 51-year-old male. And he was on somebody's wait list for a left total hip replacement, and he crashed his car and came in with this injury. And here's a couple of cuts of the CT scan. The right side had been an old replacement that he'd had in his 40s. And the left side is the arthritic left hip that was already scheduled for total hip replacement. So when you look at that, I mean, if they're already needing a hip replacement before they got injured, it doesn't make much sense to just fix it. And in this case, we just repaired the periprosthetic fracture with a revision arthroplasty on the right, and we did an acetabular reconstruction and total hip replacement on the left. And I brought this case up just to illustrate the fact that there are obviously trauma surgeons who have a secondary interest in arthroplasty, and that helps when you're doing a case like this. But if you're a trauma surgeon who relies on a partner, you have to have really close collaboration for these sorts of cases where the decision is it just going to be a fixation, or is it going to be fixation plus total hip replacement? So if you don't have the expertise to do it all yourself, you need to have a good relationship with a colleague who does. So here's another case, and this is a lady who just fell over. And she'd been on long-term prednisone, and she uses a cane in her right hand. And that's a good thing, because just 3 weeks ago, she fell and broke her left proximal humerus. So, you know, she's still able to use the cane in her right hand, but then she fell again, and she has this injury on now her right side. So just have a look at that, and we'll use this to kind of launch into what the considerations are for what you should do, or what the options are and what you might do, and how you would think about managing this patient. So the variables after this session that are associated with fixation failure, I hope you'll understand those based on the literature and some of our experiences. And to be able to plan a management strategy for fragility acetabular fractures. And occasionally that management strategy needs to include combined fixation and a total hip replacement. And we'll just put the risks of this combined procedure into context, because there are some perceptions that this is an extremely risky or complicated procedure, and I'll try to shed some data on that for you. So very quickly, I'll just talk about non-operative treatment for fragility acetabular fractures, or for any acetabular fracture for that matter. And in the fragility context, it's really, if you've got a palliative situation where the patient is non-ambulatory or moribund and they're just too sick to do anything, and then rarely if you've got a stable fragility fracture with a concentric hip. And in 25 years of working at Sunnybrook, I've treated one of these cases with so-called secondary surgical congruence non-operatively. So I think this situation in our center, at least, is fairly rare. And what about the idea of, well, we'll treat them non-operatively and then we'll do a total hip later if they need it. And so the way I think about that is, if it's a non-operative treatment plan, the patient requires mobilization. Otherwise, you have the complications associated with bed rest and traction and so on. And most of these displaced fractures are quite painful to try and mobilize. Obviously, that doesn't apply to sort of an undisplaced little crack or something like that. But if you've got a displaced fragility fracture, it might be very difficult to mobilize that patient. And then you're juggling pain medication versus the need to mobilize. And finally, if you're going to do a total hip replacement, if you're planning to do one later anyway, why not do it now? And that's where people have sometimes thought, well, it's too risky or it's too complicated. So this plan of non-operative treatment and later total hip replacement is considered by some. So here are a couple of recent or fairly recent sort of literature articles, and one's a presentation that hasn't been published yet, at least from the Academy in 2016. And we've also done an instructional course lecture on this subsequent to that lower paper in 2017 or 18. And basically the mortality rate is fairly low. And these are elderly patients. You would expect that there'd be some degree of mortality associated with the stress of surgery and the stress of the injury. The infection risk is quite variable according to the literature reviews, but generally speaking, fairly low in most of the papers. The dislocation rate associated with a total hip replacement with this combined procedure, fairly significant. And the heterotopic bone is quite common. And those are sort of the more common complications that are discussed. So there is certainly a complication rate, but it may not be as high as people might think. So here's another case, a 66-year-old male, and he's had a prior stroke and he's had an MI and he's independent at home, but he's not a healthy 66-year-old. So physiologically, he's much, much older than that. And here's a fracture on the left side, again, just from falling over. And just have a look at that AP, and we'll show you some Judet views there. And so what are the factors with this anterior fracture pattern that he's got of fixation alone failing? So let's just go through those. The main factors are all related to the inability to obtain or maintain an anatomic reduction. And the factor that we don't often talk about, but that's very important, is the surgeon and the team experience. So if it's an inexperienced team, then the ability to achieve that goal may be impaired. Older patient age, femoral head or neck injury, and cartilage impaction of the weight-bearing area. So let's just focus on that variable, which is an important one, true impaction of the weight-bearing area, and bring up Jeff Anglin's gall wing sign, which is often misinterpreted. So you can look at that obturator oblique and you can draw a little gall wing sign and get all excited that that's an area of impaction. But in many cases, it doesn't really represent impaction per se, it's just a displaced fragment. So there you can see that fragment that makes up the large part of the apparent gall wing. And there's that piece again displaced. And you can imagine if you just push that piece down, the gall wing sign would go away. And here's that piece that's not marginal impaction, that piece that's displaced. These areas are. So where you see the two areas, there's impaction of the head on the one view, on the coronal view, and on the axial view, you see some very typical impaction with this pattern, this anterior pattern, fragility fracture of the posterior and superior area. And these are impacted areas, and they do represent a potential issue. So just formulate in your minds your management plan for this fracture. And here's the way I analyzed it. I thought he was at fairly low risk of fixation failure. He does have some minor impaction of the head, and there is some minor posterior impaction. And then this issue of weight bearing comes up, and I'll talk about that a little bit because I think it's an important variable to consider and discuss. So is it important that he maintain post-op weight bearing, or if we fix it, can we just let him go and weight bearers tolerate if we fix it in a stable fashion? So this is a 7-year x-ray, and I haven't seen him since then, but he hasn't come up for a total hip replacement. And we accepted an imperfect reduction, and he did well for that period of time. You can see he's got joint space narrowing. You can see where the arrow is. He does have a notch still out of his femoral head. He had that pre-op, and it didn't seem to be a problem because probably it wasn't in the weight-bearing area. So his post-operative plan was a toe touch weight bearing. At the time I was doing all of these elderly patients were still toe touch weight bearing, and that factored into decision making. This has come up in previous talks that were presented. So just a very quick, you see there was only one plate on that. When might you consider an intrapelvic plate? Well, this piece here, when you've got the head displacing and there's anterior comminution, I find very difficult to control with just the J plate. And in that situation, I tend to add an intrapelvic plate to push that piece back and to help keep the head in place and not subluxing into that area, anterior comminution. So for this particular case, an anterior pattern like this, I think has a fairly low risk of failure. And my practice has been delayed weight bearing for all of these. So maybe let's talk a little bit about the early weight bearing that some people have been trying. So here's an 84-year-old gentleman, and he was being treated by his chiropractor for general weakness and urinary frequency, and fell off his chiropractor's table. Now, he's not a well 84-year-old, but he does live alone, and he has a house, and he has to go up and down stairs. And here is his fracture. Now, again, if you look at that, there's a large displaced piece that's pushed up. And here are the Jade views. And again, a very similar anterior pattern. This one, it's a hemitransverse. It does go through the posterior column. And you see those two areas of some cartilage being pushed out of the way, and that's true impaction in addition to the large displaced piece. But I thought, I did fairly well. I thought I got that put back together. I thought we pushed it down. And if you look at the x-rays critically, you might say, well, there's still some residual medialization. And I think there is, but he's weight bearing is tolerated at 2 weeks. And if you look at the two arrows, I think, the medialization is there, but it's not as extreme as you might think just looking at that obturator oblique, because he does have a flare on even his normal side. So this was during my let everybody weight bear as tolerated phase. And at 2 weeks, he was happy. He was walking with a walker. He was doing very well. And you can see his staples are still in. We took his staples out at that visit. And then at his 3-month follow-up, he wasn't very happy. He wasn't doing so well. He was still walking, but barely, and using a wheelchair for most of the walking and or most of his mobilization. I guess he can't walk with a wheelchair, really. He was mobilizing mostly in a wheelchair, and here are his x-rays. And, you might say, well, has the fixation failed? I'm not sure that the fixation has failed, but what's happened is the head has penetrated through those areas of previous impaction, and he has clearly failed in terms of his function and needs to have something done. And after his total hip, he was happy again. So my thoughts on this case, which I think was helpful to me, there was some residual medialization. I didn't get that fully corrected, and maybe I didn't really buttress those impacted areas enough to allow him to be immediately weight bearing as tolerated. But I do think that he would have been less likely to fail, having done this kind of case many times in the past with toe touch weight bearing for 8 to 12 weeks, that I think the early weight bearing contributed to his failure. And this and a few other cases sort of made me go back to, in these fragility fractures, either having them toe touch weight bear, or if I didn't think they'd be able to toe touch weight bear, to consider another type of procedure besides just fixation. And you might say, well, does it matter that he failed? At least he was ambulatory, and you can always do a total hip, and that's true. But I think, one operation in an 84-year-old is better than doing 2 operations. Maybe we should have done a combined fixation and total hip. He had some impaction. He was 84. It's hard to say. I think, again, in my experience, if we'd have let him just toe touch, he might have been fine. But here's another case to think about. This is a 76-year-old, and she was a pedestrian struck by a motor vehicle. So she's actually a trauma patient in the true sense of the word. And she has a number of other injuries. And here are her trauma films of the right acetabular fracture. Now, she doesn't have a gall wing sign, but she has something that, in my opinion, is far worse. She's got a flat line. Cartilage is, around the hip at least, is meant to be curved. And if you see a flat line, that's probably because there is some significant and true impaction, not just a displaced piece that you can put back down. And here is that flat line. That's a nasty bit of impacted cartilage without much subchondral bone behind it. And you can see the typical location of the posterior superior impaction, but in this case, again, fairly significant sort of impaction. So I thought that she had some significant risk factors for fixation failure. She's older, but really has very poor quality bone. And I think she has true impaction. The femoral head looked okay. And, that's one of the risk factors to consider. But I also thought that with her other system injuries, she needed to mobilize as quickly as possible. And our plan was a combined fixation and total hip replacement immediately. And you can see the fracture pattern there. And again, that anterior sort of displaced fragment. We did this supine on a radiolucent table, but I rarely use fluoroscopy personally. You can see everything. It's fairly rudimentary. It doesn't have to be a perfect reduction and fixation. So I tend to just do this without fluoro. And how many windows you use, that's really up to you. Use, one window, the so-called modified stop or AIP window, or do you use 2 or 3? It doesn't really matter. The principle is to get it fixed in a stable way so that your total hip acetabular component is going to be stable. And then you can do whatever you want. You can do an anterior hip approach, you can flip them and do a lateral or posterior approach, whatever you're comfortable with. But I think once you've done that, you need to be able to get the mobilized immediate weight bearing is tolerated, or you really haven't moved the patient functionally along. This is Joel Matta, who has published extensively on this and has a very large experience. And I personally use a sort of a longer plate and try to anchor it more cranially and medially. And this is what was done in this particular case. You can see an intrapelvic plate as well, because I thought that would help anchor the cup. And then the uncemented cup and the cemented femoral stem. So far, we've talked about just anterior fracture patterns, and most of those fragility fractures are indeed anterior. And about a quarter of them are posterior, and here's a case of that. So this is a 73-year-old, and he's out there. He enjoys hunting and hiking up in the north part of our province. And he's had a bypass before, but and he's got some hypertension and so on, but he's a pretty active 73-year-old. And he had an ATV accident, and here's his hip fracture dislocation. You can see the hip still dislocated there. It was pulled on. Looks a lot better now that it's relocated. And here is a CT scan. You can see that he's got femoral head involvement. He's got marginal impaction. And let's just consider, I think, the risk factors posteriorly. Well, they're very similar to the risk factors for fixation failure, as you would see in the anterior patterns. He's older. He's got femoral heck or neck injury, which is a bad prognostic sign. There's another risk factor is wall comminution and presence of a hip dislocation and impaction of the weight-bearing cartilage. So he's got all those risk factors there. So it was fairly straightforward to make a decision there that he would probably do better with just a fixation and total hip replacement. You can do a Gibson or Coker-Langenbach approach. You need to do something that gets you to the back, and you want to take the rotators and the capsule off the femur. People that do posterior hips, which I don't routinely, are very comfortable with this. And then another little pearl that I suggest to you is obviously minimize stripping of the posterior wall, but you do have to get into the joint, so you can leave a little bit of a capsular cuff, but the lag screw to fix the posterior wall as you're putting the reamer in is a really good idea, because if you've just got the leg, or if you've just got the buttress plate and you put the reamer in and you pull the reamer out, that posterior wall doesn't have a lot of things holding it in place, and it'll flip into the joint on you, or at least I've had that experience until I got smart enough to put a lag screw in to hold it in place so that when you pull the reamer out, the posterior wall stays where you've secured it. And then you can use whatever type of total hip you want. And always you want to buttress that posterior wall. And the total hip is really your choice, but you do want to do that from a posterior approach, I think, if you're doing a posterior wall fixation. And this guy was out hiking again at 3 months and pretty happy. And I don't think if I'd fixed him, he would have had nearly as good a result. So in summary, these are the risk factors for fixation failure with a fragility acetabular fracture: older age, femoral head or neck injury, a hip dislocation, posterior wall comminution, and true impaction of the weight-bearing surface, and that is of the dome or the posterior wall. And be careful calling a displaced piece an impacted piece. Often it isn't. And there's some controversy about this weight-bearing issue that I've raised. And personally, I've reverted back to delayed weight-bearing. I think that I've had some failures that I wouldn't have had if I'd kept people off of it. And to think of it, we wouldn't normally let even an elderly person weight bear immediately on a complex tibial plateau fracture or any other articular injury, say of the pilon or the distal femur. So I think that I was probably being a little overzealous with trying to get these elderly patients weight bearing immediately. And the combined procedure, the perception is that it's really difficult with the anterior patterns. I don't know that that's really the case. The perception is that it's really easy with the posterior wall fracture patterns, and maybe that's not so much the case either, because I think you can get into trouble. And I'll just leave you with this final evidence-based recommendations review by Andy Schmidt. And the bottom line is what's circled there. Most fragility acetabular fractures should be fixed by an experienced team and not replaced. If you're replacing the majority of these cases, you're probably replacing a few too many. So thank you very much for your attention.
Great, Hans. That was outstanding. So I appreciate your time in that talk. We're going to move on to the next session now. So I'll get so we'll have what I would consider to be a very interesting session coming up with the next two speakers who will share with us some difficulties they've had with some pelvic and acetabular cases. You've seen a lot of talks with a lot of really pretty slides and some outstanding cases, and obviously things don't always go exactly as we planned. When you're doing big complex surgeries, sometimes we have big complex problems as a result of that. And we've had a couple of very experienced speakers coming up who have agreed to share some of their difficulties and challenges they've had in the operating room, so that hopefully we can learn from things that they've learned in a little more painful fashion. So with that, I'll turn it over to Claude SAGI, who has a very large experience and has most all of his being outstanding good outcomes, but he's going to share with us a couple of difficult cases he had that didn't go so smoothly as he had hoped. So Claude, I'll turn it over to you.
Thanks, Steve. All right, we'll just get right to it. We'll see how horrible this turns out. This is a lady who's involved in a motor vehicle crash, and she has a sacral fracture, vertical shear with disruption of her anterior pelvic ring, as you can see here. And this is her CT scan cuts, and a couple of things that are interesting to note about this CT scan, if I just go back and forth here a little bit, are, clearly it's a vertical shear, and you can see that it has there's a large gap in the sacrum with, it's not impacted. It's obviously not inherently stable sacral fracture by any stretch of the imagination. You'd say that even perhaps the inferior aspect of the sacroiliac joint, as you go more caudally, is disrupted as well. And, these sorts of things often are accompanied by this. And this lady has this, flank ecchymosis. And really, this is just a marker for internal degloving on her, and is a horrible injury. And you know, with this look at the soft tissue and this type of a fracture, you know, the thing is, how do you end up taking all of this into consideration to try to come up with as close to an anatomic reduction as you can, and a stable reduction, in other words, that you can maintain with some sort of a fixation construct you're choosing, and not get into problems with complications. And, you know, here are some of the mitigating factors for her that really, I think, made this difficult treatment decision for me. And, you know, a vertical fracture, comminuted sacral injury, and this coronal clearly shows the disruption of the L5-S1 facet joint, coupled with what looks like a bad soft tissue injury and internal degloving. And because of all of this, you know, the decision really is, do you do an extensive posterior approach to try to reduce this anatomically and stabilize it, and or roll the dice with the soft tissue, or do you try to mitigate those potential problems with the soft tissue injury and go for a less than perfect reduction and percutaneous fixation and roll the dice there, with hopefully, you know, hoping that you can maintain the reduction with your minimal fixation. And so, you know, I chose the latter because of the concern over the soft tissues, and she had some other injuries that I thought were going to keep her in bed and really not mobilizing too much. But this is what happened within a week of the surgery. So we were happy to do an open anterior procedure and try to stabilize her percutaneously, and with a closed malreduction. You can see here, I put up on the left screen, this is not the resolution of the case, and this, believe it or not, is not the complication. So I'm trying to speed things up here, just showing you some of the key aspects of this case. But, you know, first mistake is, well, all right, SAGI, if you're going to try to do this percutaneously, you know, try to get a better reduction than that. And also, if you're going to try to stabilize such an unstable posterior pelvic ring with percutaneous fixation, why such chintzy posterior fixation, right? It's a partially threaded screw to try to get some compression through the fracture, hopefully, but it ends, you know, the posterior fixation is hanging off just, what, you know, 2 centimeters worth of screw or 3 centimeters worth of screw. You can see it broke, it's right where the fracture is. And so this fixation, I mean, inadequate is an understatement, obviously, for what I chose to do in this situation here. So, but now the question is, it's not like this is a couple of months and the soft tissues have had a chance to heal. This is only 1 week after the index surgery. The anterior pelvic ring is holding together, but this has clearly failed. And so now for me, the conundrum was, well, okay, do I have to somehow bite the bullet and now work through this soft tissue, or do we accept this malunion and in lieu of trying to do something heroic and end up with a really bad soft tissue problem? And of course, I decided to try to make it better. And this is her degloving lesion here. You can see how extensive that is. I mean, you could put your whole forearm into this wound right around her flank, is how badly she was degloved there. And put her prone, and this is what we ended up with in terms of the reduction. And here is how she ended up 8 months down the road. And the reason I'm showing this case in particular is that there are a number of, I think, judgment errors and technical errors that led to complications here you could argue could have been avoided or not, whether you decided to take a different course of treatment. But we'll just go dissect them here. And they're salient because of, I think, I brought it up because of this triangular fixation construct or unilateral spinal pelvic constructs and these very unstable fractures and the things that you can run into if you don't adhere to certain principles when you're doing it, soft tissue problems notwithstanding. So first and foremost is you can see, yes, there are now antibiotic bead chains in here because, of course, that wound dehisced. It got infected and she wasn't healed. And that all happened early within a few weeks. So we had to debride that multiple times and put antibiotic bead chains in there to try to resolve her infection. Problem number two, as you remember, there was that disrupted L5-S1 facet joint. And for me, that's actually an indication to do this type of a procedure. But what did I do wrong and not really take that into consideration? Well, I distracted, because you can see this is not a good reduction of the sacral fracture. The left posterior pelvic ring is still cranially displaced. And it tried to distract across the spinal pelvic construct here, but instead of reducing the sacral fracture, all I did was further distract the L5-S1 facet joint. So a really important point to remember when you're doing spinal pelvic or lumbopelvic constructs, particularly if they're unilateral for unilateral vertical shear fractures, is that if you distract across this construct, you can distract the L5-S1 facet joint. And because the vector is also from medial to lateral and usually anterior to posterior, when you compare this point of fixation to that, if you distract across this construct, you actually end up displacing the fracture and gapping the sacral fracture, which causes a loss of reduction, and you end up with a non-union because you haven't closed the gap in the sacral fracture here. So you end up with a sacral fracture gap, and remember that sacral fractures heal in kind of a peculiar way. They, I guess they sort of spot weld, or you get certain areas where they fuse and other areas where they don't. They don't make abundant callus as a general rule. So you can't really expect the sacrum to fill this gap and overcome a malreduction, or if you have to try to compress if you can with a fully threaded, or a partially threaded screw rather than a fully threaded positional screw, which you can change out afterwards if you want to get thread purchase. That's really the issue is not creating a fracture gap. So those are a couple of issues, I think, with spinal pelvic constructs that you need to keep in mind so that you don't get these complications.
Great, thank you, Claude. I know it's very painful to relive a case like that when you go through it because of the amount of time and effort you put into it and the number of surgeries. Going back through it is always painful, but in a couple of questions. One is, I know you have a lot of experience with spinal pelvic fixation because that's you're spine trained as well, and it's nice to see that understand some of the complications that happen there. But question I would have is, in looking back at this case now in retrospect, at some of the decision points and where you diverted, what would you do differently, if anything, or is this just something that's inevitable with this type of injury?
Well, I would like to say the latter, of course.
And you might be right, by the way.
Well, and I think to some degree, maybe, but I think with a case like this, first of all, better transacral screw, fixation, corridors notwithstanding, if you think that you can have them. This patient had corridors for more transacral screw fixation. You can see here at S2 and S1, both are corridors for, 2 transacral screws at 2 separate levels. So I think 2-level transacral screw fixation. And, in this situation, I honestly, as much as I'm not a real fan of the construct, I actually think it, like transiliac plating, posterior, it's not really a tension band in this particular scenario, but that type of a construct would have been nice because you can do that through a much smaller exposure and less of a soft tissue insult to the patient. So if I go back and look at this, if I had to relive this whole case, I would do 2 full-length transsacral screws, one in S1, one at the second sacral segment, and then a posterior tension band construct for this one.
Great. Well, Claude, thank you very much. That's a great case, and it's a good learning experience for all of us. So thanks for sharing that. So
Indeed.
If you could stop sharing your screen, and we'll let Ray bring his screen up. And while Ray's bringing his screen up, I just want to remind everybody that after Ray's talk, we have a very special closing. We're going to have some special comments from Drs. Eric Johnson and Dr. Keith Mayo, and I think it'll be worthwhile sticking around for that final session. So, which will add another 10 minutes to the end. So. With that, I'm going to turn it over to Ray, and Ray's going to take us through another experience where things didn't go exactly as he had hoped or anticipated, and kind of things that we can learn from that. So Ray, I'll turn it over to you.
Yeah, thank you, Steve, and thank you for having me be part of this discussion today, and certainly the whole course. And so we'll talk about special problems and when things go wrong. And my dad would tell me, who's not an orthopedic surgeon, by the way, he'd tell me to learn from the mistakes of others, because you won't live long enough to make them all yourself, and so sometimes I think it's nice to see other people's mistakes, and I'd like to share with everybody a mistake that I made probably about a decade ago that I still think about. And so my educational goals are, we're going to talk about the diagnosis of pelvic fractures, especially or acetabular fractures, especially those that may or may not be associated with pelvic ring injuries. We'll talk about imaging details and being careful with your planning, the hazards of combined injury, and really the consequences for your patients when it comes to misdiagnoses. I just have a single case of a 38-year-old woman that I took care of just a little under a decade ago, and she was a driver in a motor vehicle collision. It had come in with a EHL and Tibant firing 0 out of 5, and she was hemodynamically stable and was by laboratory accounts a victim of polysubstance abuse. And this is her AP pelvic radiograph that you see on the right side. And some of the things that sort of stick out to me here, this is, oddly enough, this was somebody that had come into our institution. I was away. I think I was teaching an AO course. She had a fractured dislocation of her right hip. I see a disruption of ilioischial-iliopectineal lines. I see posterior wall and dislocation of the femoral acetabular joint. Her Jade views would confirm that as well. And so we'd arrived at diagnosis of transverse posterior wall. I think that it's worth mentioning that at the time she didn't really have a formal reduction attempt, but had been just kind of put in traction. And these are a decade-old two-dimensional images that we had achieved with our CT scan. You can see that her head's a little bit better under her dome. She had had a myelogram just a couple days prior to this because of chronic low back pain, and that's why her CT looks a little unusual. You can still see the dislocation of the femoral head relative to the intact acetabular dome. And then her CT scan here, and I'll just try to run through this. You can see her residual myelogram dye. She has a normal appearing sacroiliac joints, at least to me. You can see her comminution through her transverse, as well as her posterior wall segments, and some intra-articular debris that's present. And so she'd come in on a Friday, and Monday morning, first thing, I was able to take her to the operating room, and we'd placed her prone. I like to do a Coker-Langenbeck exposure prone and put her on a flat top table. And these are just some of the fluoros images from the operating room. And one of the things that I noticed at first was I was having a real hard time reducing her transverse portion. I was having a real hard time lateralizing her femoral head. And so I've had people tell me that, lateral traction is good, and it's not my common practice, but I thought that, maybe this was the time to use some lateral traction. And so instead of a Shands pin, I'd placed a hook that you can see over the greater trochanter, still couldn't get it quite right, and then used a clamp that was placed through the greater sciatic notch to clamp the transverse, and boy, it just still wasn't quite right. I think the femoral head was a little bit better lateralized, but I wasn't terribly happy with my reduction. And so sometimes I use a femoral distractor, one time docked into the ilium and one time docked into the femur to restore length. And maybe length was my problem. And so I tried getting length. And you can see there's quite a bit of length. If you really look carefully, you can see there's bending in my Schanz pin that's in my ilium. And so I'm really working hard, trying to get length back to help restore this correctly. And that didn't work, and got a clamp on there and just really wasn't very happy with my acetabular reduction. And then this is where I start sort of blaming the circumstance. You know, maybe if she had a better reduction, or maybe if she didn't have her femoral head sitting on the back of the acetabulum for 3 days, then it wouldn't be such a problem. Well, then I put a Schanz pin in the ischium, and I'm trying to lateralize the ischium directly while putting a clamp and still cranking out on our femoral distractor, trying to achieve length. And I'm getting close, but I'm not terribly happy. And then I finally talked myself into a reduction. I put in some instrumentation, and this is what we have here. Here's our AP pelvic radiograph, and it appears to me, at least, the femoral head is underneath the dome. But then when you look at her obturate or oblique view, you see that it just isn't quite a concentric reduction. If I could bring the audience's attention here, you know, you can see this, the acetabular dome is here, and then we get, I wouldn't call this a real Gall sign. This isn't a Gall sign, but rather a lack of reduction of these columnar components. And certainly the overall acetabular anatomy is not concentric with our femoral head. Here's our AP pelvic radiograph postoperatively. Iliac and obturate or oblique views that you see. And then postoperative CT scan, which I think in a way demonstrates to us what the bigger issue was. It's subtle, but her sacroiliac joint had widened somewhat. And so seeing that, we had a talk with a patient about revising it, and she just wasn't, terribly keen on the idea. And so I think that might be my mistake in there. And just to sort of show you how important these subtleties of reduction may be, I've put these dates here. I've put the date only because just to show the audience how long of a problem this had occurred to the patient. She was operated on February 8th, 2011. This is her post-op AP radiograph. She'd come in at about 6 weeks, and she was having quite a bit of pain, but really wanted to walk. She was sort of on baseline narcotics anyhow, and so pain control was a real issue with her at the time. And so she really wanted to walk, but we kind of held her off because I wasn't terribly satisfied with the union, especially of her transverse component of her acetabulum at the time. And this is March in 2011. Here she is about at her 3-month mark, and she really wants to walk. And it was really kind of hard to see her, to hold her back. And you can see now, in addition to her acetabulum, we're having some incongruity of her symphysis pubis. She's not having pain there. She's having pain really in her anterior hip. So she gets to walking, and then she comes back in August, and boy, this is about 6 months, and you could see the geometry of her femoral, or of her acetabulum just kind of melting away right in front of us, and just really wants pain medicine and doesn't want any further intervention at this point. And she comes back in December of that year with you know, you can see that she's got a limb length inequality. She's got almost an acetabulum that seems to be dissolving right before our very eyes. And then she kind of goes away for a while. And these are these are films that she had brought back to us once she had come. She had gone to go see a joint replacement surgeon for second opinion, and you can see the flattening of the femoral head, and there's apparent union of her her columnar components of her acetabular fracture here, but very apparent limb length inequality. And then she comes back the next year and she says, good news, I went and I got a total hip replacement. And then bad news was she got infected and she came to see one of our partners, and she noticed the date here. This is 2015. This is now 4 years after her index procedure. She'd gotten an infection. She'd seen one of my reconstruction partners who does a great job with revisions, and she had gotten an antibiotic spacer, which had broken. I think she had a revision antibiotic spacer. She had gone on to have a revision arthroplasty with a cup and a cage, which had gotten infected. And she had undergone another 2-stage revision to a new a revision prosthesis, which had got infected. And she had had multiple stages. And here she is, the last x-ray that I see, she sort of followed up with one of my senior partners and seems to be doing reasonably well and is still hooked on narcotics. But they seem to have the infection that's under control. And so I show you this date. This is 2/19/2020. And to summarize what went wrong, I think I didn't have a good diagnosis, both preoperatively and intraoperatively. Some of the image details I missed, and I missed those really intraoperatively, which I'll show you on the next slide. And these combined injuries, I think, have to be taken very seriously. And when you have a transverse fracture pattern, I think you have to carefully scrutinize both the symphysis pubis and the sacroiliac joints, both the contralateral and ipsilateral sides. I think Dr. Krieger last week showed us a very nice case where he had a challenging injury that was very, very similar to this, but I think he had a whole lot better clinical and hopefully a whole lot better radiographic and hopefully clinical result than I did. The consequences can be great, because I had a bad day in the operating room 10 years ago. This woman has had a bad decade with a hip, and I think a lot of that's on me. And so to summarize, if I were to see something like this next time, this to me is the key where I was focusing on the femoral acetabular joint. What I should have recognized intraoperatively was this widening of her sacroiliac joint that I did not see on her preoperative CT scan. And frankly, I just barely see on her postoperative CT scan. And so if you ever see this in your practice, if this ever happens to you, I think you have to have the comfort in yourself and recognize the injury and stop and change your plan. And at this point, I think if I were to do it again, I would deal with the sacroiliac joint. If I were you, I would deal with the sacroiliac joint in whichever way you deal with the sacroiliac joint to obtain proper reduction of that femoral acetabular joint. And so the planning and the imaging details are important, not only in pre-op, but in intraoperative theater, because sometimes your plan has to change based on the problems that may come up. Again, combined injuries can be very serious, and this little subtle incongruity of this sacroiliac joint, I think, made for a bad outcome for this patient in the line. And so these misdiagnoses have consequences, and most of the time, you're not the one that's living with them, it's your patient. And so, boy, that was really uplifting stuff. And so to summarize, I think you have to be very careful. These are serious injuries, even in experienced hands. So there you go.
That's great, Ray. And I can tell by the difficulty you have presenting it that these things take an emotional toll on, and when you put your heart and soul into it and you have an outcome that's not what you want, it really does. It really is. It beats you down. So it's much better to have it work better. Do you have an algorithm in your own brain now? If you get in, we all had that situation where we have a transverse fracture pattern that we think we're just going to clamp and it's going to come together, and we do that, and we are off a few millimeters, and we just can't. You change positions of your clamps and you fiddle with it, and you pull on the head and you pull on. Yeah. You do a lot of different things. And do you have in your own brain now sort of a what do you think of next, and where do you go if you've spent the last hour doing the same thing, putting clamps on?
Yeah. You got to do something different, so for me, the funny thing of it is I've had this very same case a couple of times after this operation. And one of the things that I like to do that's very powerful, it's time consuming and it's a little bit painstaking, But if I were to have this case to do over again, I would stop. I would close her Coker-Langenbeck incision. I would put her supine on a radiolucent table, and I would put chance pins in her anterior inferior iliac spines. I would use a femoral distractor or an intraoperative X-fix to close that SI joint, assuming that it's an incomplete SI joint like we have here. And then I would obtain screw fixation, stop. I'd put her back prone, open her Coker-Langenbeck back up, and then fix it.
I think that's a thoughtful way to think about it. I mean, the other option, of course, would be to do an open reduction of the SI and maybe the anterior approach to the acetabulum. A lot of different things to think of, but I think your point is good. You have to stop doing the same things over and over again and hoping for a different outcome, I guess. But we've all been there. So thanks, Ray. That's a great case. And if you could stop sharing your screen now, I'll pull my slides up here. I promised you that we would have a final session here that hopefully you'll enjoy. So our special closing. First of all, I just want to thank everybody for their participation, and I want to recommend this book to you. There's a lot of good publications out there, but I think this is the basis for understanding the radiology and understanding fracture patterns. Everything is explained there in this book. And I'll point out if you open this book and you go very early into it, what you'll see is this dedication, which I'll have to put my readers on to read this to you, but I want to read parts of it to you. And that would be, as you see here, this is Letournel's comments. It's a great pleasure for me to honor the members of the Acetabular Fracture Club. The promotion of acetabular fracture surgery has now been passed on to them. They already know the specialty as well as me and practice it with very similar enthusiasm. All the members came to Choisy many times, either to improve their knowledge in this field or to discuss with me the most difficult problems these fractures represent. He goes on to say that they did multiple courses, always with one goal in mind, the improvement of acetabular fracture surgery. And out of our mutual interest in this acetabulum, we have become close friends. So I would say that if you look, two of those people are a much younger version of people that we see here in our course. We're fortunate to have two faculty members who are part of that, this whole evolution, and a very key, that small group of people, including the two members of our faculty today, very key in bringing this discipline to North America and teaching the rest of us. And from that, it's grown into something that's pretty amazing when I look at the quality of work and the much broader understanding of it that existed in the past. So, so with that, I am going to turn it over to Dr. Johnson. I'll stop sharing my screen so Dr. Johnson can bring up his screen, and he's got some comments to make. And then we will have Dr. Mayo come on to do the final closing comments. And then I'll have just a couple of comments to add to that. So Eric, I'm going to turn it over to you and appreciate you joining us for this part of the program.
Okay, welcome to this final session of the acetabular fracture course produced by AO North America. This is the final session of the last session. And I've been asked to give a talk on some of the aspects of acetabular fracture surgery historically, an introduction of how Emile Letournel performed his operations, what he was like, where he had to live. And then I'm going to sort of morph this into some career challenges and try to give you an explanation why Emile Letournel became Emile Letournel and the struggles that he had to get through. So Emile Letournel is seen here both on the right image in the operating room and at the celebration of his 1000th acetabular fracture accomplishment in Paris. And you can see some of the other members of his group that studied with him. And I think just to take this picture on the right and just kind of imagine you're in the operating room with this individual. He was excited on every time he got to the operating room. It was a challenge to him and he enjoyed his work. Contributions of Letournel are many and they're not all listed here. He reported the first series of 75 cases in 1961. Developed the ilioinguinal approach in 1965, developed the extended iliofemoral approach wrote 3 textbooks, began the first pelvic educational course in Paris in 1984, continued to teach until the last month before he was diagnosed with cancer, and he died August 14th, 1994. He had the oldest and the first database of fractures, and he would spend hours each week updating this database so it was accurate. He established a passion and a camaraderie for acetabular surgery, established the first pelvic referral center, developed the first instrumentation set of implants and instruments, and his classification, which is in his main book, has lasted the test of time, and it is still the world's gold standard. Percentage of his good and excellent results under 14 days are listed here by diagnosis at the bottom. And you can see the excellence of his technique with 95% in transverse and both column and posterior column fractures. Even the T fractures were a high percentage of excellent results. And then continuing down, he averaged over 80% good to excellent results in his series. And this was verified by Matta's series later in the 2000 generation of series reported. And they all are at least greater than 80% good to excellent results under 14 days. We had a classic symposium as I was the guest editor in CORE, Clinical Orthopedics Related Research, August 1994. We brought out his first article on his first study of his 75 cases. It was a eulogy to him. Unfortunately, he died just before this book was published, and he never really got to see the journal. So back in Emil's career, I think this is part of how Emil developed into who he was at the end of his life. He was born in a small island, Saint-Pierre-et-Miquelon, over here just south of Nova Scotia. This is in the North Atlantic Sea off North America. This is Province Française. This is French territory. And he grew up, was born on this small island. Montreal is over here on the left. The St. Lawrence Seaway is through here. And we'll go through a little bit of his life. And you can see the struggles that he had to overcome to get to the point where he was. Some early images of Emil, kind of a handsome little boy. You can see the type of stereo system that he had at the time. Here he is at, I believe, a Catholic church meeting and an award for his achievements. He's got his double-breasted suit, which he seemed to wear throughout his youth. Here he is a little bit later, growing up. You can see the harsh conditions that he was surrounded by, and his life on this island was basically fishing, boat repair, and construction. So he wanted something better for his life. And doing his genealogy, I found out from the son of a mother that was his classmate that he would spend Saturdays walking with his red wagon and his hammer and his chisel to his uncle's garage and house to learn carpentry. So he was adept at surgical experience. This is Langolade on the left. This is the section of St. Pierre, the isthmus and where people live. This is a harsh environment. And you can see him, he wasn't overly developed in the upper extremities at this time, but he was a great guy, and very chiseled face and very handsome. So in doing his genealogy, his family was the Letournel family, and his mother's family was Pichon. And they were from Manche, France, which is near Normandy, northwest France. And this picture here is a satellite view of the island where he grew up. This blue periwinkle house is his home. At age 17, he took a boat, Cap Bleu, to Montreal on the 28th of July, 1944, in order to go by himself across the Atlantic during the end of the war to get to Paris to learn his education. He subsequently got to Paris, and in Paris you can go to medical school. It's like going to college, but you don't become a doctor until you do your residency. So he had finished his schooling. He wanted to do orthopedics. he went to speak with Robert Judet, and the interview was short with Judet. When he talked to Judet, he had no letters of recommendation. He had no family presence in Paris. He had no money. They had no family money. And Judet said, I don't have a position for you. And as Emile was leaving his room and shutting the door, Judet asked him where he was from. He says, I'm from St. Pierre. And Judet said, you start tomorrow. And because of that relationship, he then went on to form his Letournel School of Acetabular Surgery and trained quite a few people on his techniques. So there's a difference between these two people. The one on the left is a young man trying to get ahead and trying to make a better life. The person on the right is an established Parisian surgeon, very famous family, and well-to-do. So there is a struggle for Emile to achieve his greatness. And that part of it is what made him what he was. So this is his house in St. Pierre. It's being torn down. They subsequently built a secondary school there with his name as the title of the school. So he's quite famous on this island. And I've run into quite a few contacts through emails about his life and how he grew up. So his accomplishments: pelvic classification, pioneered the concept of pelvic and acetabular fracture center, brought acetabular surgery to the world. He was, however, also excelled in social life. He was a bon vivant. He loved his band de Letournel, and he was a great friend and a mentor. A couple of pictures from Caesar's Palace a few years back, where he would be excited to get his picture taken with some of the waitresses, and he was just on top of the world. He lived his social life like he lived his life in the operating room. He was known for golden hands. This photograph got him in trouble. This was published in Le Figaro, the yellow newspaper of France. It was published because of Emile's success, and Emile would take care of the Formula One drivers. And the Formula One drivers knew the French Michelin chefs. And he started then taking care of the families of the Michelin chefs. And it would be no problem for him to call up on a Friday or a Saturday night at 6:30 and get the best table in town at the best restaurant, for as many people as he had in his entourage. So, but the French surgeons were a little bit upset that he got such advertisement in the paper, and that increased his animosity amongst them because he was so successful, he was so famous, and they weren't. So he had an incredibly strong personality. He never was afraid of any surgical case. He would not accept average. And he always made his best effort to fix the fractures correctly. So why did he have this personality? I think I've got some answers. His personality was special. He would never, ever quit or be defeated. He would never accept mediocrity. And he had one thing else. He had a generosity of his spirit. He was a joy to be around. So I'm trying to maybe give an explanation where this generosity of his spirit and the qualities of his surgical technique came from. This is a video taken in 1992, I believe, in Den Haag, the Netherlands, at a pelvic and acetabular fracture course. He had just gotten off the plane and arrived at the start of the meeting. And he's giving a talk on normal radiology of the acetabulum.
Thank you. Good morning, ladies and gentlemen. Of course, I am able to speak in your own language, and as usual, I have to turn to English. And it's a great pleasure for me and also an honor to be in your country. And I hope that we'll have today's work interesting. And anyway, for me, it will be, I'll say again, with great pleasure to try to transmit to you what I have learned during 30 years of acetabular and pelvic surgery. And I like always to remind that I was the assistant of Robert Judet for more than 20 years, and he asked me to work on the subject in the late 50s, and I am still working on it. I don't know if I learned everything, something every day, but I must confess that yesterday I had operated a case which is unique in my service, so it gives me some courage to carry on the work. The first one, please. The two columns are bone. The anterior column, which extends from the anterior part of the iliac crest up to the pubic angle. That's three parts, upper, middle, and inferior ones. And the posterior column is linked to the other one a little above its midpoint. The posterior column is massive and more adapted, I should say, to internal fixation devices. Therefore, I asked for the
This second video is a video that was found by Michel Aransky, orthopedic surgeon from Rome, who spent time with Emile after the group of us did. And he happened to be at the French embassy in Paris one afternoon and was getting some things taken care of. And he saw on a pile of film, old film, the name Letournel. And he asked the consulate if he could take the film, and he did. And they said, sure, we're going to throw it away. So these are films 1969 in French. I'll just show a short portion of it, of Emile describing his discoveries about the acetabular fracture classification, the mechanisms of injury, and a little bit on his fixation techniques. So this is 402 cases, 360 have been operated on.
Les fractures du cotyle sont en réalité des fractures des massifs osseux qui circonscrivent la cavité cotyloïde. Le cotyle est situé dans la concavité d'une arche ayant pour clé de voûte le toit du cotyle et que limitent deux colonnes. La colonne antérieure, ici représentée en blanc, oblique en avant et en dedans, elle est grêle et de relief tourmenté. La colonne postérieure, ici peinte en rouge, est volumineuse, solide et verticale. Pour étudier une fracture du cotyle, il faut 4 clichés. Le cliché de face du bassin, qui dépiste les lésions bilatérales. Le cliché de face de la hanche, sur lequel nous étudions systématiquement 6 éléments. Le détroit supérieur, la ligne radiologique ilio-ischiatique, expression de la tangence des rayons au 4/5 postérieur de la surface quadrilatère, l'U cotyloïdien, les bords antérieurs et postérieurs du cotyle, le toit du cotyle. Les obliques à 45 degrés sont obtenus avec un rayon normal tombant sur un bassin dont l'axe transversal est oblique à 45 degrés par rapport à la table. Pour l'oblique obturatrice, c'est la hanche blessée qui est surélevée. Elle permet l'étude de la colonne antérieure, du bord postérieur du cotyle, du cadre obturateur, de la région suscotyloïdienne externe. Pour l'oblique alaire, c'est la hanche saine qui est surélevée. Elle permet l'étude du bord postérieur de l'os iliaque, du bord antérieur du cotyle, de la totalité de l'aile et de la crête iliaque.
So why was Emile so involved and so unique among surgeons of our current time? He had strong principles. He grew up in a very difficult area of the world. He was forced to take care of all varieties of orthopedic disease. He had no help. He was in a workman's compensation hospital in the south of Paris, and here is the world's best surgeon. But he was forced to be the end of the line referral center for this hospital in this area. So his surgical skills came from managing his surgical storms. So I want to bring in another concept here, Julius Wolff, and we all know as orthopedic surgeons, we know Wolff's Law. But I think Wolff's Law may have an application to the human personality as we go through this a little bit and try to compare Emil to his maturation from the storms he had to encounter in his career. Julius Wolff was a German anatomist and a surgeon, died in 1902, worked at Friedrich Wilhelms Universität in Berlin, student of Bernhard von Langenbeck. He came up with his magnum opus 1892, that bone will adapt to the load applied to it. And the reason for that is the bone is protecting itself and it makes itself stronger for the next load. So Julius Wolff on the left, his law of bone transformation in the middle. And this is a book full of calculus. He was a very technical mathematician, and he spent his career trying to figure out this law. So if we take Wolff's Law and compare it in nature, this is a dramatic comparison between two types of trees. The tree on the left is an ancient bristlecone pine tree. It's only found in one spot in the entire world. It can live to 4,000 plus years old, and it lives at the top of a mountain. The storms hit the top of the mountain more than they do the sides. The trees on the right are aspen trees and aspen grove in the Ashley National Forest, Utah, United States. They're never at the top of the mountain. They're always in groups, and they're very flexible. They never take any brunt of a storm. So there's a comparison here of Wolff's Law in nature between load and what load can do. And for the aspen tree, if they're subjected to load, they fracture. They don't have any previous history of remodeling to load as Wolff's Law, and they can't manage heavy storms. They get destroyed. In contrast, the bristlecone pine lives because of the storms. They go to 4,000 plus years old. They survive at 10,000 feet. Their roots are in shale rock and alkaline soil. Nothing else grows there. It's an old lake bed. The tectonic plates and earthquakes push these mountains to 10,000 feet. There's limited water. They endure 40 centuries of storms. They grow 1 inch a year in girth every 100 years, 1 inch every 100 years in girth. They survive because of Wolff's Law. The trees that find better water and better soil grow fat and die early. The trees that find the worst possible spot to put their roots survive the longest. So the bristlecone pines adapt to storms. They're located here. This little red dot here is on the central part of the White Mountains on the eastern border of California and Nevada. San Francisco would be directly to the ocean side over here, Los Angeles down here. This is a schematic from Google Earth showing you where these pine trees are located. It's a 24-mile ride up the mountain from Highway 395 on this red dotted line to this one grove. These are the White Mountains on the right. The Sierras are at the bottom. This is the Owens Valley, and this is Highway 395, one of the better driving routes in the United States if you like cars. But to get up to these mountains, it's almost like you're going to a temple. These trees are massive. They're twisted. They have, the front part of them is usually dead from the previous centuries. The trunks are distorted, and they have very broad bases, and they survive because of the storm. The very small pine cone on the left is about 1 inch to 1.5 inches, and it can produce these enormous trees. So there's a key here, and I think it applies to the humans. You can see how these trees are desolated. Nothing else grows up here. And these trees have managed to survive millennia because of certain principles. And you can see what the storms do to the wood. It twists the wood and torques it. but the trees get bigger and wider bases and they get stronger because of the storm. So adaptation to stress, trees at the tops of mountains. This is the classic example of Wolff's Law in nature. So Letournel's book, published in 1982, was a storm to orthopedics. Basically brought up a topic that nobody knew very much about. In the AO manual at the same time, there were a few pages dedicated to wall fractures, and I think a posterior column or a posterior transverse fracture. That was it. They had some small plates on it. There was nothing else. Emil compiled his work and published it. It had all the answers. It was difficult reading at first because of the terminology and the concepts and the three-dimensional mind to kind of understand these pelvic problems. But comparing the book to the clinical cases began to make sense. It was another storm and it changed orthopedics. So a day routine for Emil was up at 5 a.m., 4 espressos before surgery, change in the office, secretaries present, off to the OR running 2 rooms frequently. At lunchtime, a bottle of red wine with the team, back to the theater till 6. If the cases went well, champagne at 6:30, and then singing about 8 o'clock at night until 1 a.m. with the chefs in a local restaurant. He was a bon vivant. He loved life. This is his hospital on the left. This is one of my original slides. This was a workman's compensation hospital. It wasn't the premier hospital in Paris. It was in a small place of Paris in the south part. But look at Emil on the right. Look at the smile on his face. He was going to experience his passion another time. He was ready to go. Very short guy, a little bit broad, but immensely talented, immensely strong, and nothing could stop him. Nothing. This is his hospital from the ground level. Not very impressive. And the metro stop here, the hospital is down here with the turquoise top. And the metro stop, I think, was on this side of the intersection up here. So very small, isolated place, but he became the best in the world. So there's a principle here of Wolff's Law, and I think it's Wolff's Law in the human condition and the human personality that created someone like Emil. Emil would not die. He could not be pushed over. He fought back on every opportunity to gain strength and technique skills. So here we are, the tree and Emil. There's a difference between here. Emil's alive and can talk. Emil had one other quality, had generosity of his spirit. He was an amazing person to be around. He was always fun to be with, and he lived his life to the fullest. He would work in his office between cases. He would work at nights, on the weekends. And when he was at work, he was at work. But when he was out on the town, he was the bon vivant. He was the center of attention, and everybody enjoyed Emil Letournel. So Emil and surgical stress, these are his storms, like the tree has storms on the bristlecone pines. He weathered them all. He learned from the mistakes. You don't learn from doing something easy and you have a good result. You never learn anything from that. You only learn from your mistakes or the difficult case. So he would make mistakes, he would figure out how not to make them again, and then he got better. He made himself stronger. So in the end, a difficult case to Emil was just another storm. He'd done it before, it wasn't a big deal, and he was more interested in where he was going to have lunch, despite the fact the case was difficult. So Wolff's Law, I think, applies to humans. Bones react to load, humans react to stress. If we're successful in managing our storms, then we get stronger and our skills get better. So that's the key, managing your storms. So there's also one thing that you will find in certain people in orthopedics. If you look at the history of orthopedics, there's individuals who by themselves pushed the envelope and made things change. And Emil did this, but Emil had a quality that I have not seen in very many people, and that was his generosity of his spirit. And if you are at this AO course and you are interested in AO surgery and AO trauma or AO subspecialty, you should make every effort to affiliate yourself with your regional or your country's AO organization. They will accept you. It's an open fraternity, sorority. It's camaraderie. We do things without being paid for. We enjoy the company of other surgeons. We learn from other surgeons. We develop contacts with international people. And I can email or text any one of my friends and a picture and an image, and within a 4 or 5 hour period, I'll get an answer back no matter where they are in the world. And it's because of the organization of the AO. It is unique in the world. There's nothing else as fantastic as the AO Foundation. So bristlecone pines survive because the storms push the bristlecone to the edge. And when it does that, it makes resin. Resin protects the wood. The wood cannot be destroyed. There are no natural hosts at 10,000 feet to decay the wood. It's wind and sand and ice storm erosion is the only destruction of the wood. The resin, we do the same thing with our surgical cases. The resin from our difficult cases, and we're successful, makes us stronger. So you increase your resin with your difficult cases. So the application of Wolfslaw to surgeons and to you guys who are going to be AO surgeons is to dedicate yourself to excellence, technique, become the best of the best. Education above the competition, weather your storms, recognize the patriarchs who got you where you were or are, become a bristlecone pine to younger surgeons, encourage them, have generosity of spirit, make them feel welcome, and increase the resin of your character. So examples to sum this up, Julius Wolff's Law on the left, the natural tree example of Wolff's Law, and Emile Letournel as the human example of Wolff's Law. So in my 30 years, this is what I've learned. I hope I've learned some more, but this is what I've got on my slide. Difficult cases challenge the surgeon and challenge them. You learn from your mistakes. They are the teaching points of your career. Restore axis, length, alignment of fractures. Use compression and loading of fixation whenever possible. Get advice. Be gentle as possible with the soft tissues. Survive your discouragements. Don't quit. Don't go into something else. Stick it out. You'll survive. Complex surgery is a career learning curve. Mistakes are made early and less frequently throughout your curve experience. You learn from those storms. Never give up. You get through the storms, and you're an example of Wolff's Law. You also need to do another thing, is develop a passion for what you do. The surgeons that have given their talks this past session, starting in July, have a passion. When they go to work, they're not working. They're enjoying their passion and their challenge. So your career should be a passion, not just work. Make sure that that's prioritized in your future goals. Career storms change you. So you'll become stronger as your career matures, and you'll become more experienced, and you'll get more gratification and satisfaction from the surgery and the teaching that you do. So the question then is, what will you become now in this early part of your career, and as you look forward to what you're going to do? And my suggestions is you take this example of Wolff's Law and try to apply it to the rest of your careers. You also need a career that never stops learning. You always try to learn new techniques. Change is part of life, and those who don't change are left behind. So when change warrants a change, then you should accept it. Develop a group of friends that you can confide with and get consults from, and get career colleagues. You can do this through the AO very easily, and you'll become internationally connected to people who are doing the same things that you do, the same interests. And education is also something you should strive to take part in. Try to educate people, try to make a change in surgical care of patients. So just in a summary, my request of you is to make contributions to patient care. Make contributions to science if you're in an academic center or if you have the desire to do that. Constantly teach new techniques, learn the new techniques, become experienced with them. And with this kind of combination of things, you should be able to advance the care of your patients to the best possible care available. but also remember the generosity of your spirit. You should have one. And when you're in a teaching situation or an interaction situation, you be responsive, exciting, try to teach them something that's new, and help them along in their careers to mature. Thank you very much.
So with that, I'm going to turn it over to Dr. Mayo, who's going to take us home and then wrap up to give us some closing wisdom here and close up the course. So Keith, I'll turn it over to you. And I'll give you a couple of minutes. So I need about 2 minutes for this. So basically just, it's sort of with mixed emotions that we get to the thing at the red here, which is, as I look, there's nothing below that. And I would say this is basically the end of the course, and there is not a homework assignment like we've had in the past, but I guess with that, I would say that it's not really the end, it's a beginning. And the homework is going to be to take forward what we've learned over the last 8 weeks to try to take better care of our patients. I want to thank the faculty that came together to pull this course together really over a fairly short period of time, and I think stepped up. And these are some of people that I look up to and learn a great deal from, and learned a great deal in this course, and really appreciate their efforts. I certainly want to thank Mark Reilly and Dave Stephen for the countless hours of work they put in along with me to help get this course up and running, and I can't thank them enough, and they are true friends and true mentors and outstanding surgeons. So with that, from our standpoint, I'll just say thank you very much for your participation. Thanks for the questions that you've asked. They've been really good, and more importantly, thank you for your interest and your passion for this topic. And with that, I can go back and see Keith, are you?
Yeah, I've got my control bars back, so let's try this again.
Well, so when you're done, Keith, that will be the end. So we won't need to come back to me, and I appreciate you coming through. So let me stop sharing mine. I'll turn it back over to you.
All right, do we have that?
Yep. Yep.
All right.
Great, thanks.
Okay, so I have. It's a great pleasure and an honor for me to attempt to put 50 years into perspective, which is a challenge because I've been doing it for 37 years, and many days it seems like it would take another 37 to get to where I want to be. So this is a historical summary and a very brief treatment of current and future problems with a focus on career development, which I think in many ways has actually become more difficult with the passage of time. The legacy from the viewpoint of the acetabulum, you've seen the book, but unless you've read this article, I think this is a unique article within orthopedic literature. This is a JBJS American edition, 1964, which essentially gives us 98% of what we needed to know about treatment of pelvis and acetabulum. The next iteration was in 65 when the adaptation of the linguinal was universal, but at this point, virtually everything was there. And so what did he give us? He had an understanding of the osteology of the innominate bone, which was unique. That formed the basis of his understanding of radiology. He gave us a clinically useful classification system. The Coker-Langenbeck had been already developed by Judet and Lagrange, but he developed the iliolinguinal and then took the Smith-Peterson into the extended iliofemoral. He pioneered all the reduction techniques. Every clamp that you've ever seen on this planet was envisioned by him and tried and was always laying on the back table. He was the supreme educator. This course has a direct lineage going back to the first course in 1984. He was extraordinarily gracious, non-judgmental, and his relationship with Judet is, I think, emblematic of what we would all love to have in our career. And that's a mentor who encourages us and thrives and is not threatened by our success. And certainly an example of that we can see in the results, which the two large series from his own and then Joel Matta who can basically trace his lineage directly back, as we all can, to Emil's teachings. So one person largely responsible for virtually an entire field, unique in my experience. What's come since then? Well, we have certainly some augmented imaging capabilities. That includes both pre and intraoperative assessments. Surgical approaches have continued to evolve, and that includes posterior lateral approaches with a trochanteric flip, the anterior interpelvic, and then a variety of other retroperitoneal anterior approaches, pararectus and others. The other thing that's happened is that I think 10 to 15 years ago, we used to debate whether there was ever an indication for total hip arthroplasty. And with the changing in demographics, that's been, I think, a sea change, and our ability to adapt with that is actually very critical. I've also listed navigation. I think that I've been looking at navigation in this field for 30 years and doesn't seem to have ever come to clinical fruition. And then for the acetabulum, I see a vanishingly small role for closed reduction and in situ percutaneous fixation. The challenges are these, and that is the results have plateaued. The best results are still those portrayed and documented in Letournel and meta series. We've already seen the changing epidemiology, with the skewing toward older patients, which in virtually every series have a poorer outcome than their younger cohort. And then the most difficult of all these issues is the workforce health system consideration complex. So I think in Europe and North America, we have in many ways created a delusional effect by training many trauma surgeons. And so that virtually every level 1 and level 2 center in the United States, and approximately the equivalent in Europe, has somebody who feels they are capable of managing these injuries. And if you add to that the barriers to referral, if you've been hired by an institution that expects you to do these injuries, then referral is an admission of defeat and will routinely bring down the administration on your back because of considerations about financial reimbursement, et cetera. And then I think we're all laboring within the issues of resource restraints, but I don't see any future where that's going to let up. I mean, we've seen the world economy is devastated by the current crisis, but healthcare economics is a daunting challenge going forward. On the pelvic ring side, the distribution of contributions is much broader. We have the classifications brought forward by Pennell and Tile, and then further modified by Young and Burgess, and Letournel himself, based on mechanism, considerations of stability and anatomic side, as well as associated injuries. Open reduction was largely pioneered, although not much published, by Letournel, followed by Joel Matta, Sven Olerud, and many others. It included both anterior and posterior approaches to the pelvic ring. The next, I think, advent was that of the pushing the envelope for closed reduction and in situ percutaneous fixation. I think Joel would probably not want to be mentioned here, but certainly his initial imaging techniques were those that formed the basis for further developments by Chip Rout and others. And we've obviously enhanced our imaging protocols many times over the ensuing 20+ years. And there probably is some role of navigation, although most of that, I think, the navigation is intracranial. The other things that have impacted pelvic ring injuries is early field or ER stabilization. I think this has been a huge boon to our outcomes. And certainly we have improved care of the polytraumatized patient, beginning with use of blood management, blood product management, ventilator management, on and on and on. So we have much better colleagues from that viewpoint. The challenges for the pelvic ring are that as we've increased the number of patients that are managed with closed reductions in internal fixation, we've had fewer and fewer opportunities to work on our open reduction skills. And since we're human, we like to do things that we feel most comfortable with. So if we do open reductions infrequently, then we frequently reach a point of diminishing returns. We also have to deal with the changing epidemiologies you already seen earlier with older patients, an entirely different set of clinical problems, and then all the same issues that we talked about as far as the acetabulum is concerned. I have a somewhat jaundiced view of the world literature. I can probably find only 50 articles in my career that have been impactful in terms of a long-term perspective, which is about 1 to 1.5 a year. This is just an example of things we'll see in recent literature, which is this unusual frame to manage a patient with a posterior column, posterior wall fracture with this complex external fixator, which you can imagine the downstream problems associated with this, even if it's not used for definitive management, but as far as temporization. We are great believers in the power of technology. So we have this patient with a transverse posterior wall. This is not a widely known journal, but there are so many journals and so many articles that if you're bored some night, sit down on Ovid or PubMed and do a literature search, and you'll be astounded by the articles that will come up. So the solution for this was not necessarily understanding the fracture pattern perfectly and creating a surgical plan which included a perfectly executed surgical approach. It's a 3D printed composite plate which takes 2 plates and a spring plate as a single construct printed in the lab and brought to the OR, notwithstanding the fact that the cranial portion of this plate is probably putting the superior gluteal neurovascular bundle at some risk. So if you're going to spend time on your career, be very careful how you use the world literature. Solutions, I don't think that we can envision a time in the near future or even intermediate term where technology is going to revolutionize what we do. We've been talking about bone glues and endoscopic surgery and robotic surgery for at least 2 decades. And in fact, our day-to-day practice has changed relatively little, and it's based on our ability to exploit our legacies. This is maybe, in some people's estimation, mundane, but if we can come up with an accurate diagnosis and a thorough preoperative plan, as we've seen from today's cases, and then manage a soft tissue friendly surgical approach to acetabular fractures and for a certain number of pelvic ring injuries, then we're going to be at a position where then if we understand the type of reduction techniques we need for a given injury and the implant placement and function, then we will have all the tools that we need. And I think we have been essentially forced to follow considerations of other anatomic sites where we now see anatomic plates for virtually every condition. And there's been a tendency to think that we can have a single use preoperatively generated CAD/CAM plate for each injury pattern. And I think the problem with that is that it leads us away from understanding what plate function is and where the plate should go, as well as the understanding of how we convert from clamps to screws and plate function. This is a German article from the 80s, which I think is just an early example of the correlation between the percentage of good outcomes on the left and the number of operations per year. I think this is exceedingly optimistic, so that we see if you can do 10 cases a year, then already you're in the 70%. And these are short-term follow-ups. And frequently our failures are not nearly as egregious as the one on the right, but the more subtle ones are equally damning to the patient over the long haul. So the question is, since dilution is a problem for many of us, how do we deal with this? And so then we have to look at strategies to overcome training deficits. So even if we're well trained, if we've had the benefit of good training through residency and fellowship, but we have a low volume practice, which is a reality many places, then what do we do? Because 100 cases over 2 years is far different than 100 cases over 10 years, in which case you may never reach clinical competency for a given injury pattern. And this has become much more difficult with the passage of time. When I was in training, if I wanted to go visit Eric or Joel or go to Paris, I could just scrub in and operate with any of my friends. And I would do that. I would take time away from my practice. And it was facilitated by a collegial relationship, which has now been made virtually impossible by medical staff hierarchies. It can still be done, but it requires licensure and a number of other issues. If that doesn't work, then I establish a relationship to refer and assist if possible. So if you have a regional trauma center with a good resource, develop the relationship with that person or persons and figure out a way to go there and operate with them. That kind of experience can be invaluable. Many fellowships, develop your friendships and your contacts from around the world. And this has also become much more difficult because of our medical staff bylaws, but it can still be done. Frequently it takes as much as a year in planning. CME should be generally cadaver-based because that's our simulation. And if it's not just CME, a lot of the major cities now have proprietary cadaver facilities which can be exploited. You use their implants or somebody uses their implants in your hospital. The quid pro quo is to go there and use their facilities as a practice, particularly if you haven't done an approach in several months to a year. Go there first. Online resources are highly variable. Review those with somebody you trust before you blindly follow them, because there's some really, really bad content available. And then develop a pathway for remote consultation. And now that we have Zoom up and running or meetings or other software options, develop a relationship with somebody that you know and trust and be able to go over difficult cases step by step. Simulation may ultimately become available. We are a profession that has adapted some aviation principles. One of the aviation principles which we don't have is that, which has been longstanding in the aviation industry, and that is that long-haul pilots, because of the duration of their flights, transatlantic, transpacific, would frequently never have enough landings and takeoffs in their schedule to maintain currency. And that, since that's where most of the accidents happen in the first and last phases of flight, then you would have to go as a pilot on the line to a simulator to make up for your deficits in landings and takeoffs. And you'd have to do that every month or every other month. Someday we may be mandated to do this. Right now, the currently available simulation comes nowhere near reality, but I remain hopeful for that. Ultimately, this is a career which demands long-term self-critique and a commitment to skill enhancement. Despite all of those things, there are very few careers in orthopedics or any area of medicine which are more gratifying at the end. So with that, I will end with Emil's encouragement. He has given us so much, and he used to always end with bon courage or carry on. And with that, I want to thank you all for your participation and encourage you to pursue this as far as you can within your own individual careers. Thank you.